Respected physicians and medical students, welcome you all to today's session on basic electrocardiography. আজকে আমরা অত্যন্ত লাকি, আজকে আমাদের সাথে আমাদের স্পিকার এবং চেয়ারপারসন দুইজন ইন্টারন্যাশনালি রেপুটেড ফিজিশিয়ান আমাদের সাথে যুক্ত হয়েছে। আমাদের সাথে আজকের সেশনের স্পিকার ডক্টর রফিক আহমেদ স্যার এবং আমাদের আজকের চেয়ারপারসন প্রফেসর মাহমুদ হাসান স্যার। আমি প্রথমে যেহেতু রফিক আহমেদ স্যার আমাদের সাথে আজকে ফার্স্ট সেশন, আমি স্যারের পারমিশন এবং চেয়ারপারসনের পারমিশন নিয়ে স্যারের প্রোফাইল একটু পড়তে চাচ্ছি। আসলে স্যারের প্রোফাইল পড়তে গেলে পুরো দিনব্যাপী পড়া যায়, কিন্তু আমি 2-3 মিনিটের একটু সময় নিয়ে একটু পড়ছি। আমি চেয়ারপারসন স্যার, আমি প্রোফাইলটা পড়ে শুরু করছি। Dr. Rafique Ahmed was born at Mymensingh, Bangladesh in 1955. He is the son of late Dr. Abu Ahmed, Associate Professor of Pathology, and late Mrs. Aziza Begum. He graduated from Rajshahi Medical College in 1978 as the top student of his class. He served as assistant registrar and registrar at the same hospital and went to Japan in 1982. He trained there in cardiology and electrophysiology at Nagasaki University Hospital and also got PhD in medical sciences in 1988. He worked as a registrar in cardiology at Westminster Hospital in London between 1988 and 1991. He moved to USA in 1991 and trained at University of California School of Medicine and at Massachusetts General Hospital of Harvard Medical School. He is board certified in internal medicine, cardiology, and cardiac electrophysiology. He is a fellow of American College of Cardiology. He was awarded honorary fellowship, FCPS, of Bangladesh College of Physicians and Surgeons in 2013. He was appointed Associate Professor of Medicine and Director of Cardiac Electrophysiology at Medical College of Georgia, August, USA in 1995. He was also Associate Chief of Cardiology Section at the same hospital from 1999 to 2001. He relocated to Baltimore 2001 to join Mid-Atlantic Cardiovascular Associates, that is prestigious cardiology practice of 65 cardiologists. He is currently consultant cardiac electrophysiologist and Vascular Institute, Washington Hospital Center. His work involves providing full range of electrophysiology services. The services provided are EP study, RF ablation, pacemaker and ICD implantation, follow-up clinic for ICD and pacemaker patient, tiltable test. স্যারের সবচেয়ে বড় কন্ট্রিবিউশন, এগুলো তো ইন্টারন্যাশনালি আমরা সব জানলাম, কিন্তু বাংলাদেশের প্রতি স্যারের যে দেশপ্রেম, স্যারের যে প্যাট্রিয়টিজম, স্যারের যে ভালোবাসা, সেটা আসলে মানে আমরা কথায় বলে প্রকাশ করতে পারবো না। স্যার বাংলাদেশে ইলেকট্রোফিজিওলজিকে বাংলাদেশে স্যার এস্টাবলিশ করেছেন, স্যার বাংলাদেশে ট্রেনিং করিয়েছেন, বাংলাদেশি ফিজিশিয়ানদের আমেরিকায় নিয়ে ট্রেনিং করিয়েছেন, স্যার বিসিপিএসেও স্পেশালি বিসিপিএস এর প্রতি স্যার যত্নবান। সোজা কথা, স্যার আমেরিকাতে থাকলেও একজন অসাধারণ দেশপ্রেমিক ফিজিশিয়ান। আর আমাদের আজকে চেয়ারপারসন প্রফেসর মাহমুদ হাসান স্যার, আপনারা সবাই স্যারকে চিনেন। স্যার এক্স ডিপার্টমেন্টাল হেড অফ গ্যাস্ট্রোএন্টারোলজি, বিএসএমএমইউ, এক্স প্রভাইস চ্যান্সেলর বিএসএমএমইউ, এক্স প্রেসিডেন্ট বিএমএ বাংলাদেশ। আমরা বিডি ফিজিশিয়ানস আজকে অত্যন্ত অনার্ড এন্ড ব্লেসড এই দুইজনকে একসাথে পেয়ে। তো আমি আজকের সেশন শুরু করার জন্য আমাদের আজকের সেশনের চেয়ারপারসন প্রফেসর মাহমুদ হাসান স্যারকে আহ্বান জানাচ্ছি।
ধন্যবাদ ডক্টর ইসলামুজ্জামান খান সাহেব। আমি অত্যন্ত কৃতজ্ঞ আপনি এই সেশনটা ডক্টর রফিকের সময় বিশদ বলেছেন, তবে আসলে তার যে কৃতিত্ব সেটা বলতে গেলে অনেক সময় লাগবে। তো আপনি তার যে অর্জনগুলো বলেছেন, তিনি কিন্তু বিশ্বের বিভিন্ন দেশে, মানে জাপানের নাগাসাকি ইউনিভার্সিটি হসপিটাল, লন্ডনে ওয়েস্টমিনিস্টার হসপিটাল, আমেরিকায় ম্যাসাচুসেটস জেনারেল হসপিটাল, হার্ভার্ড মেডিকেল স্কুল, এইরকম টপ ইনস্টিটিউশনে উনি প্রশিক্ষণ নিয়েছেন। কাজেই তার মতো একজন মানে ওয়েল ট্রেন্ড এবং অ্যাচিভমেন্ট সহ মানুষ পাওয়া বাংলাদেশে তো নাই, পৃথিবীতেই বিরল হবে। আর একটা জিনিস হলো যে উনি আমেরিকাতে থেকে তো আমেরিকায় কাজ করতেই পারতেন, কিন্তু মানে মানুষের সবার কিন্তু দেশের প্রতি টান থাকে না। কিন্তু রফিক আহমদ সাহেব একটা অনন্য মানুষ, যিনি নিজের পয়সা খরচ করে বারবার বাংলাদেশে আসেন বাংলাদেশে কাজ করার জন্য, এখানে শেখানোর জন্য। উনি নিজের যন্ত্রপাতি নিয়ে এসে বাংলাদেশে কার্ডিয়াক ইলেকট্রোফিজিওলজিতে 2 জনের বেশি মানুষকে ট্রেন করে দিয়েছেন, এবং তারাই বাংলাদেশে এখন কার্ডিয়াক ইলেকট্রোফিজিওলজি করছে। আর বিসিপিএস এ উনি মানে কতগুলো অত্যন্ত মূল্যবান সাইমুলেটর এবং ম্যানিকুইন দিয়েছেন, দিয়ে উনি অ্যাডভান্সড কার্ডিয়াক লাইফ সাপোর্ট কোর্সটা চালু করেছিলেন, যেটা বাংলাদেশে এই প্রথম। এবং বলা যেতে পারে যে এটা এটা কিন্তু একটা আন্তর্জাতিকভাবে স্বীকৃত একটা কোর্স। তো এইগুলি মানে ওটা বলে শেষ করা যাবে না। এছাড়া উনি বিভিন্ন জায়গায় ক্লাস নিয়েছেন, বিভিন্ন মেডিকেল কলেজে, বিভিন্ন প্রতিষ্ঠানে, এবং যন্ত্রপাতি দান করেছেন। তো আমি মনে করি যে আমরা অত্যন্ত সৌভাগ্যবান যে উনি কিন্তু আমি বলার সঙ্গে সঙ্গে রাজি হয়ে গেছেন, এমন না যে উনি হেজিটেট করেছেন, সাথে সাথে উনি রাজি হয়ে গেছেন যে এইটা মানে আমাদেরকে দেশের যে যারা চিকিৎসক শুরু করছে, এটাকে বেসিক্যালি মানে যারা শুরু করছে তাদের জন্য বেশি উপকার হবে, অথবা যারা কার্ডিওলজিস্ট নয় তাদের আরো বেশি উপকার হবে যদি ইসিজি পড়তে পারাটা কিন্তু এখন আসলে এইটা সবারই উচিত, কারণ এটা একটা বেসিক টুল। কাজে আমি মনে করি যে আমরা সবাই এটা শিখবো, এবং রফিক আহমদ সাহেবের কাছ থেকে আমরা এই জ্ঞানটা নিব। আমি নিজে ব্যক্তিগতভাবে অনেক কারণে রফিক আহমদ সাহেবের কাছে কৃতজ্ঞ, কিন্তু এটা ওনার প্রশংসা করা কিন্তু সেই কারণে নয়। এবং আরো একটা কথা, যে উনি যদি কিছু নাও করতেন তাও উনি আমার ক্লোজ মানুষ থাকতেন, এই কারণে যে ওনার পিতা কিন্তু আমার শিক্ষক, প্রফেসর আবু আহমদ সাহেব, যিনি রাজশাহী মেডিকেল কলেজ এবং ময়মনসিংহ মেডিকেল কলেজে প্যাথোলজি পড়িয়েছেন। আমি এবং আমার মতো আরো বহু ছাত্র ছাত্রী পেয়েছে, তো তারই সুযোগ সন্তান রফিক আহমদ সাহেব। আমি তাকে স্বাগতম জানাচ্ছি, এবং আর সময় নষ্ট না করে আমি আহ্বান করবো যে রফিক আহমদ সাহেব আপনি শুরু করুন। ধন্যবাদ।
Good morning, Assalamu alaikum. Dr. Khan and Mahmoud Bhai, thank you for the kind introduction. Thank you very much for inviting me. It's always a pleasure for me, and I consider this as part of my obligation to do anything for Bangladesh. So what I'm doing is I think it is something that we all should do. I always tell people that most of us got educated with very little money. And Bangladesh actually is, one day somebody asked me what Bangladesh gives me. And my answer was that Bangladesh paid me upfront because it educated me from grade 1 to medical school without any cost. Fed me, brought me up, and that's what I am. So my job today is to talk about ECG. I'm going to touch base with very basic ECG. ECG is basically picture recognition. And I'm going to start with one picture, and I'm sure if I show this picture to you for a fraction of a second, you will recognize this picture. And you didn't have to think why this is the picture of Bangabandhu, because you have seen this picture so many times that you recognize it. And then if I give you another picture who looks like him, you may have to think a little bit. And ECG is like that. So what we need to do is to look at these pictures and remember it. Please remember, in general practice, 90% of ECGs are normal ECGs. And if we can recognize confidently 90% of normal ECGs, then that's fantastic. And then the abnormal one will come. So next picture is a little difficult. This picture is a little difficult. I think some of us will recognize here, see Bangabandhu at a younger age. Shohid Sohrawardi. And this is a picture of Cho and Lai. And that's when it becomes complex. So what I started with is a straightforward picture of Bangabandhu, and now here Bangabandhu is a younger age. And then we can also look at a few other things. There is a person behind And what I can tell, this is an army person, and definitely not Chinese army, probably Pakistan army. And that's what ECG is all about. We look at pictures, some part of it we recognize, like Bangabandhu's. Please look at one thing. Most of you have not seen Bangabandhu from close. I saw him, I was lucky enough to see him once in 1970 at Rafique Government College. He is a towering figure. Look at, among all these people, he stands up. He is a tall, towering figure that we had. So ECG is electricity runs the heart, and that's why we can record ECG. And the ECG, the heartbeat is generated by the sinus node. Sinus node is situated at the junction of superior vena cava and the right atrium. And then the electricity goes through the atrium, through the AV node into the ventricle, through the bundle branch and Purkinje fibers. So what happens? How does it happen? It's action potential that causes it. If we look at a resting cell here, inside is negative, outside is positive. And if I stimulate it, it will reverse and it will generate an action potential and then depolarize, and then again it will go back to its resting state. And the electricity is going from this to this direction, and I'm recording from here. I will see a positive deflection, and once the whole tissue gets depolarized, there is no potential difference and it will come back to the baseline. And that's how ECG is recorded. If the electricity is moving away from the electrode, it will become negative. So how do we record ECG? With ECG machines, I'm not going to go into that, but we put electrodes in the body, in the right arm, right leg, left leg, and then in the chest. It's important to know where the location is. So the V1, V2 is at the level of 4th intercostal space. V4 is at the 5th intercostal space in midline, and V3 is in the middle, and then it goes backward. It is important to put limb leads are always put in the right place, but the chest leads can become high or low. And if it becomes high and low, then the recording will be a little bit funny. And we look at another term called axis. What is the axis? Axis means which way the electricity is going. If the electricity is moving in this direction, we will call it plus 30 degrees. If the electricity is moving in this direction, we call it minus 150. And it can move in many directions. And this is just a basic understanding of the Qrs axis. And that's actually frontal plane. And then this is horizontal plane are the chest leads. V1, you can see that V1 starts on the right side, V2, V3, V4, V6 goes on the left side. And so this is the ECG recording. I mean, this is the complexes are called P, which is the atrial activity, then Qrs complex. Please remember, even though it is called Qrs complex, sometimes there is no Q wave. First negative, without any preceding R wave, is defined as Q wave. All the positives are defined as R wave. If there are more than one R wave, we will call R dash. And any negative wave after the R wave will be called S wave. And then we have the T wave, and sometimes we see U wave. And then we measure intervals. The few intervals that we look at, we measure from PR interval. Even though it's called PR interval, we don't measure it from P to R wave. We measure it from the P to the beginning of the Qrs complex. Sometimes this is called as PQ interval, but when measurement wise, it is measured from the beginning of P to the beginning of Qrs complex. And then we look at the Qrs duration from the beginning of the Qrs complex to the end of the Qrs complex, which is the J point. And then QT interval from beginning of the Q wave, Qrs complex, to the end of the Q wave, QT interval. And this portion is called ST segment. And the Qrs complexes can be many. As I mentioned, that even though it is called Qrs complex, we can just find an R wave. We can find R and S wave. We can have R, S, and R wave. You can QS pattern, QR pattern, all these different shapes we can get depending on the location and the condition of the patient. But in general, the term of the complex is Qrs complex. So this is one thing that we always like to look at is where are the leads located? If we look at the limb leads, lead 2, 3, and AVF, they represent the inferior surface of the heart. Lead 1 and AVL on left side of the heart. AVR actually is a cavity electrode. So we can locate, if we find that somebody has an MI and it is manifested in 2, 3 AVF, we know it's inferior. If it is lateral, it will be manifested in 1 AVL. The chest lead, on the other hand, is representing right or left ventricle. And as you see, V1 is on the right side, and then as we go to V2, V3, V4, V5, V6, it becomes on the left side. So this is an ECG. I mean, I'm not going to go interpretation of this ECG, but there are a few important things that are in an ECG strip. In Bangladesh, I know that we have strip ECGs, but most of the time we have a piece of paper that comes up as an A4 paper. On the left-hand corner, there should be patient identifier. Which are those? Patient's name, patient's date of birth, patient's sex, male or female. If there is a patient ID number, it should be there. Date of the ECG and the time of the ECG. And then we also put the technician's name. This ECG is unconfirmed. Once it is confirmed, it will be marked as confirmed and the confirming physician's name. And then there is interpretation. This is a computer-generated interpretation. Please be careful about it, that when you read ECG, please ignore this in the beginning, because if you look at it, then it will bias you. So please read the ECG as you think appropriate. But like this one, this patient actually is a totally wrong ECG interpretation. I'm going to come. And then in the bottom, there are a few other things written. What is the paper speed that was recorded? 25 millimeter per second, and the calibration is 10 millimeter per millivolt. So these are the few things. Now, one thing is important, that make sure that all ECGs have identifiers. Patient name, date of birth, date of ECG. Now, if there is the kind of ECG, majority of the ECG machine in Bangladesh are a single rhythm strip, and they do not come up with the names. So please make sure as soon as the ECG is done, the patient's date of birth, name, and date of ECG should be put there. And I prefer that we mount these strips on a piece of paper, on an A4 paper. One thing that happens, that I go to Bangladesh, and it doesn't happen here because patients don't carry their medical record, and patients they save the ECGs, but over a period of time, they fade. So what I suggest, that please ask patients to make photocopy of the ECGs, because then they will last for a long time. It is very important to have old ECGs, because then we can compare. If somebody had an ECG done in 2005 and patient comes today, I can compare it. The comparison is important. And then one of the things that we report in ECGs is we always compare it to the old ECG. We say there is no change in the old ECG, or there is change. Now, I'm going to start with this ECG, and I'm going to go over a few things. So if you look at this writing in the bottom, I have magnified it. And what it is says, that the paper speed recording was 25 millimeter per second. That's the standard paper. And there is a calibration of 10 millimeter per millivolt, which is this calibration. This is 1 millivolt for 10 millimeter. Sometimes we do it half calibration. Sometimes we do double calibration, very rarely, but this is the standard. This is something is important. This is how the filtering is done. Most of us don't pay attention to it, but this is how this is filtered. Now, in the ECG paper, there are grid. It's a grid. There are small boxes. There is bigger boxes. Now, this small box at 25 millimeter per second is 0.04 second, which is 40 milliseconds. The bigger box, which is 5 of those, is 0.2 second. And then if I make 5 of them, that makes 1 second. And that's how we count it. And if this gets faded, then it becomes, then the calibration is 10 millimeter. That means if QRS amplitude is 10 millimeter, we call it 1 millivolt. So that's what the paper is all about. Now, what do we look in the ECG? We look at rate, we look at rhythm, whether it's atrial rhythm, junctional or ventricular rhythm, regular or irregular. We look at PR interval, we look at QRS duration, Qrs axis, Qrs amplitude voltage, QT interval, ST segment, and then we make a final conclusion. We have a general tendency, not only in ECG, in everything, we look at something and we want to come to a diagnosis. I think we need to get into the habit of describing it. I always tell people that if we go out to Dhaka New Market and come back and ask you that, can you describe one of the person that you saw there? You will not be able to say. But if I give you a mission that every time you will go to New Market, you will recognize one person. You will go and maybe look at a shop and find somebody and then recognize that person. So that's why when you look at an ECG, I request that you spend a little time. You give yourself a pause, look at the rate, look at the rhythm, PR interval, QRS duration, and all those. It will not take a long time. And once you keep doing it, then afterwards you will get faster. Like I can read about 200 ECGs an hour with little mistake. Remember that I'm saying little mistake because if I spend more time, I'll make much less mistake. So there will be a degree of mistake in everybody's reading. Nobody is 100% correct. So this ECG, what is the rate? Now the rate calculation, there are many different formulas, multiple rate calculation formulas. And you can find out, I use a very simple method. I look at a 6-second period and I have put it here, 1, 2, 3, 4, 5, 6 seconds. And then how many QRS complexes? 1, 2, 3, 4, 5, 6. 6 QRS complexes in 6 seconds, the heart rate is 60. And this is a good method because if I calculated based on this, the heart rate would have been less than 60 beats per minute. Over here, it will be more than 60 beats. So there is a degree of oscillation in the heart rate. 6 seconds is good. But if it is extremely regular, then just looking at 1 RR interval, you can calculate the rate. But I find it simpler to do a 6 second. But also the other thing that I do sometimes, that one standard ECG paper is 10 seconds. And whatever QRS complex in there, if you multiply by 10, you will get heart rate. Like here, I multiply by 6 because 10 seconds. Here I have 10 heartbeats multiplied by 6, 60 beats per minute. So this patient's heart rate is 60 beats per minute. What do we look next? Rhythm. What rhythm I'm looking at? Is it a sinus rhythm? Is it an atrial rhythm? Is it a ventricular rhythm? What I am seeing here, that there is P wave. Let's go back in the bottom. P wave followed by QRS, P wave followed by QRS, P wave followed. That means that this P wave is the driver and the QRS is following it. So this is an atrial rhythm. Now, is it coming from the sinus node or some other part of atria? If it is coming from sinus node, it will be coming from the top chamber of the heart going inferior. That means it is going to the electrode 2, 3, AVF. And if you remember in the beginning, I said that if the electricity is moving towards the electrode, it will be positive. And sure, P wave is positive in lead 2, 3, AVF. That means it is coming from the top right corner of the heart. And that makes it a sinus rhythm. The rhythm is sinus. And there is a degree of irregularity, but it's not grossly irregular. So rhythm is sinus and regular rhythm. Next, I'm going to look at PR interval. So how do I measure the PR interval? So I have taken just lead 2. I've magnified it. If you look at lead 2 here, that this is the beginning of the P wave, which is just before this line, and then 3 boxes, 1, 2, 3. That's 120 and probably 10 milliseconds here. So that makes it 130 milliseconds. Am I 100% accurate? No, but I think it's more or less accurate. So the PR interval in this patient is 130 milliseconds. Now, what is the QRS duration? Again, same thing. If you look at the magnified view here, you see two small boxes, and that is 80 milliseconds. If you some may say a little bit bigger, so if it is 80 or 90, and I thought it was 80 milliseconds, but it doesn't really matter if it is 80 or 90 milliseconds. It's a very minor difference. So QRS duration is 90 milliseconds, 80 milliseconds in this patient. What is the Qrs Axis? This is a term, I think this is more of an academic importance. I don't think in general practice you have to jump up and down. And if a patient student cannot answer this question, I would not really mind, but it's a good idea. So what I'm looking at, lead 1. Lead 1 is positive. That means the QRS is on this side, on the right side of the square, between minus 90 and plus 90 on this side. And then we look at AVF. AVF is positive. That means it is between 0 and 90 degrees. And that's good enough. If you just look at lead 1 and AVF, then you can tell which quadrant it is in. And if I want to go a little bit more precise, I can look at another lead, like lead AVL. Now, lead AVL is negative. That means I know it is between 0 and 90. And now I know it is between 0 and 60 plus. And that's pretty much accurate. So what QRS axis I have is between plus 60 and between plus 90, which is normal. And then what is the QRS amplitude? We look at the amplitude of the QRS complex, and mainly two leads that we are commonly look at, lead V1 and V5. You can look at other leads also to look at left ventricular hypertrophy. What is it? If you look at this one, it's about 1 millivolt in S in V1, and R in V5 is 1.5 millivolt, is 2.5 millivolt, which is normal. Next, we look at the QT interval. Again, I'm going to bring up that ECG. If you look at the QT interval, beginning of the QRS complex to the end of T wave, here are two small boxes, one big box, and three boxes. So basically, it's two big boxes equivalent, which is 400 milliseconds. So the QT interval is 400 milliseconds, which is normal, and you can correct it for heart rate. And if you want to do that, you can look up the formula, but anything less than 480 milliseconds is normal. Then we look at ST segment and T wave. The question is, ST segment, if you look at this one, the PR segment, baseline, and ST segment is the same line. And that's isoelectric, that's normal. ST segment can be elevated. That means it has gone up, or it can go down, depressed. And please remember that if there is acute ST elevation, we can call acute MI or pericarditis, but ST depression, I report it, but I will not scare the patient that you are going to die now because your ST segment is depressed. So we have to be careful. We always say ST segment depressed, consider ischemia, but we do not make any very strong comment. So if I look at this one, if I look at ST segment in all the leads, limb leads and chest lead, they're isoelectric except here in V2, you can see this little, that's a normal variant. And sometimes you can see similar findings. Now, how about the T wave? How do I know T wave is normal? Here, T wave is negative. Here, T wave is positive. Over here is negative. So what is correct? General rule is T wave follows the direction of the Qrs complex, except in V2, V3 sometimes. So you see here, Qrs complex is negative, T wave is negative. In V5, Qrs complex is predominantly positive, T wave is positive. And the exception lead is V2. Same AVL, Qrs is down, it's looking up. That's an exception location. But majority of the cases, it will be in the right direction. And if I see something different, then I'll call it T wave abnormal. So in this patient, ST segment was normal, T wave was normal. And now I'll make my final conclusion is normal ECG. So after all this, and I suggest that when you read this ECG, please follow this pattern so that you You analyze them and make a final comment. And this is a normal ECG. Please remember this picture. And if you keep looking at this similar picture, you will recognize them. Majority of the ECGs. So I will need a volunteer to do this ECG. Anybody? I can't see everybody's name, so if somebody will, and please remember that in ECG, nobody is. We all sometimes struggle with ECGs, and I'm going to give you the heart rate in this patient. It's about 138 beats per minute. Any volunteers?
Dr. Shafiqul Islam, please. Hand raise course. Onik, Dr. Shafiqul Islam kete ano.
Thank you, sir.
Okay. Can you tell me what the ECG is?
Sir, rate is around 150 beat per minute. Rhythm is regular and sinus rhythm.
Why do you say it's sinus rhythm?
Sir, because I have I can see the P waves before each Qrs complex.
And what else?
And PR interval is also normal.
No. One more thing, not only there is P wave before each QRS, but P wave is upright in lead 2, 3, and FEF.
Yes, sir.
If this P wave was inverted, it will not be sinus rhythm. So this, you are absolutely right. Sinus rhythm, okay. And the PR interval?
Sir, PR interval is
how many boxes?
Three small boxes, 120 millisecond.
Yeah, a little bit more than 120 is fine. So 120 millisecond, fine. And then QRS duration?
QRS duration is normal 80 millisecond or
80
less than, yes, 80 millisecond.
80 millisecond. And the QT interval?
QT interval is within normal range.
No, that is not a right answer. I want the number.
Oh, yes.
You see, here I'll give you the number. This one big box and then two small. So it's about 280 millisecond here.
Yes.
How about the Qrs axis?
Seems like left axis deviation.
No, lead 1 is positive, so it's on the right side, and AVF is neutral, so it's 0 degree. Probably fine. How about ST segment and T wave?
ST segments, sir, no, normal, sir. In V3 it is a little bit depressed.
Okay. Yes. So let's go by lead. Let's go by lead. V3 is depressed, right?
Yes, sir.
V4?
Sir, depressed.
V5?
Sir, depressed.
V6?
Sir, it is also depressed. One small box.
Okay, and how about lead 1?
The lead 1 is also showing ST depression.
And lead AVL?
Sorry. Yes, sir.
Okay, so please look at this. Interesting that V4, V5, V6 is on the lateral side of the left ventricle, and lead 1 AVL also lateral side. So there is ST depression, and it's a downslooping ST depression in lead V3, V4, V5, lead 1 AVL. How about the
Yes.
T wave? T wave?
So T wave, there is inversion in the lateral leads.
Yes, which leads?
The 1 AVL,
Yes.
P6, and also
Yes.
V5.
Yes, V5 and V4 is biphasic. So what is your final conclusion?
So my final conclusion is lateral ischemia with sinus tachycardia.
No, first sinus tachycardia. First thing
Yes.
first.
Yes, sir.
Okay. Sinus tachycardia, lateral ST wave changes, consider ischemia.
Oh, yes, sir.
Yes, we will never commit because it is the job, because you have not seen the patient. You are reporting the ECG, and that's what I'm not with the patient. So what I will say, yeah, fantastic job. There is one more finding. If you look at lead V1, we did not talk about the P wave, will come in a later date, but there is the latter terminal part of the P wave is little deep. So there may be left atrial. So fantastic, wonderful job. So sinus tachycardia, normal PR interval, QRS duration, QT interval, in lateral STT wave changes, consider ischemia. And that's the way to do it.
Thank you, sir.
Thank you. Next I want one more volunteer, please. And I'm going to tell you the heart rate.
Dr. Devdas Pal, please.
Okay, heart rate is 48.
Dr. Devdas Pal, please.
Thank you, sir. Thank you, sir.
Yes, go ahead. So
Please.
can you do this ECG? I'm giving you the rate. Rate is 48.
Yes, sir.
What is the rhythm?
The rhythm is regular.
And where is it coming from?
Coming from.
Is it sinus? Is it ventricular? Is it junctional?
Yes, sir. This sinus rhythm, sir.
Why do you say it's sinus rhythm?
Sir, there P wave is present, sir.
Yes. So there is P wave before. So rate 48, rhythm is sinus and regular. You said there is a P wave, and this P wave is a little funny, but it is upright in 2, biphasic in 3, and probably upright in Levier, but also biphasic in VR. So sinus radical rate 48. Rhythm. What is the PR interval?
The PR interval is almost 200 milliseconds, sir.
Little bit less than 200. It's about four boxes, 160. Please remember one thing. When you report ECG, commit yourself to a number. Because we always have a tendency, we all like to, not only you, I also like to, I don't want to commit myself to a mistake. Like I say, maybe 200, but I will always say, please try to say 160.
Your resolution, sir, around 80 milliseconds.
Yes, 80 milliseconds, perfect. And the QT interval is very difficult to measure in this. I'll tell you this. Here is one big box. It's about 440 milliseconds. Now tell me about the ST segment and T wave.
There is T wave inverted in lead on, lead AVL.
Yes. And how?
And T wave flat in V5 and V6, sir.
Fantastic. And what is the final conclusion?
Sir, there is sinus bradycardia and bilateral ischemia, sir.
No. You see, this is the funny part, that you made a comment that ischemia.
And
what you found, you just found a flattening of the T wave. If you look at the one before, there was ST depression. Just flat T wave does not mean that there is ischemia. So I will describe the finding. I will leave it alone there. I will not call it ischemia. The one before, with sinus tachycardia, there is definite ST depression. This one, there is no ST segment depression. So thank you. I mean, you did wonderful. So final conclusion, sinus bradycardia, diffuse T wave flattening. That's about it. I can't say anything more than that in this ECG. Thank you.
Thank you. Thank you, sir.
Okay. Anybody else? And one more person.
Sir,
I'll give you the rate.
Sir, প্রথম দুইজনের জন্য দুইটা বুক আমরা গিফট হিসেবে ধারণ করে ফেললাম।
Oh, fantastic. Good.
দুইজন দুইটা ইসিজি বই আমাদের কাছ থেকে গিফট পাবেন স্যার। আপনি যদি স্যাটিসফাই হয়ে স্যার ক্লিয়ারেন্স দেন, আপনি আনসারে স্যাটিসফাইড, তাহলে স্যার আমরা বই গিফট দিব স্যার।
Yeah, sure. So I want somebody
thank you so much, sir.
This. I'm going to give you the heart rate. Heart rate is 66. Somebody, can you?
Rashidul Hasan, please. Rashidul Hasan, please. হ্যাঁ রাশিদুল হাসান আপনি হ্যান্ড রাইজ করছেন প্লিজ
Go ahead. Can you?
আসসালামু আলাইকুম
So the heart rate is 66, and then you do the rest of the interpretation. Okay. Somebody in the background, can you turn on the speakers? Okay. Rashidul needs to be on.
নেক্সট ওয়ান এনিওয়ান তিনজন হ্যান্ড রাইজ করছেন যে কোনো একজন কে করেন পাঁচজন হ্যান্ড রাইজ তো সবাই করতেছে ওকে আমি ডিসাইড করতেছি ডাক্তার সৌরভ দাস প্লিজ
Sir.
Yes. So the heart rate, I gave you the heart rate 66, and then you start with the rhythm.
Sir, this is sinus, POF is present, sinus arrhythmia, sir.
No. You see, the golden rule is that I am not asking for a diagnosis today, and not
Sir.
ever. I never diagnose in the first glance. I want a reading of this ECG. So sinus rate 66, you said sinus rhythm. Why did you say sinus rhythm?
Sir, upward POF in lead 2 and biphasic in V1.
Yep. So that makes it sinus. Okay. And then is it regular or irregular?
Sir, regularly irregular.
There is a pattern to it, right? So there is starts with slow, gets faster, gets slow, gets faster. What? Okay. And why is that? Why is this irregularity?
Sir, possibly sinus arrhythmia, sir.
And why do you think it is sinus arrhythmia? I mean, I can say, if I argue that this is not sinus arrhythmia, what is your point in favor of sinus arrhythmia? Okay, I'll tell you this. This paper is 10 seconds, right?
Yes,
If
sir.
it is sinus arrhythmia, this oscillation will be same rate as the sinus, as the respiration rate. It changed twice. Slow, fast, fast twice. That means in 10 seconds, it moved twice. Times 6, 12. That's the rate of respiration. You understand?
Yes, sir. Yes, sir.
Yes, so it's exactly the pattern of respiration. So 12 breaths per minute. Okay, sinus rhythm, sinus arrhythmia, PR interval.
Sir, 1, 2, 3.
Three
Point.
boxes.
1, 2, 3. Sir,
Yeah.
0.12 seconds, sir.
Good, normal. PR interval. Qrs duration.
0.8, sir.
0.8. Good. No, 0.08 actually.
0, sir. Sorry, sir.
Yeah,
0,
80 milliseconds.
yes,
80
sir.
milliseconds. Then QT interval, I'll give you the QT interval. It's about, it's 400 milliseconds. Now, ST segment.
Sir, normal ST segment, sir.
Is it not normal ST segment? Isoelectric. T wave.
TF flat on lead 3, sir. Otherwise normal.
Yeah, so actually just one lead and I can accept that. So what is your final conclusion?
Sir, person with heart rate 66 with sinus arrhythmia.
Good. So your final conclusion is sinus rhythm with sinus arrhythmia. Will you call it a normal ECG or abnormal ECG?
So age of the patient.
17.
So yeah, possibly normal.
Yep. So sinus rhythm, sinus arrhythmia, normal ECG. That's a normal variant. Thank you very much. You did wonderful.
Thank you, sir. Thank you, sir.
Okay, next one. I want one person to do this ECG. I'm going to give you the heart rate. Heart rate is 78.
এবার মোসান্না সোবাহান প্লিজ
Assalamu alaikum, sir.
Rate 78.
It's 78. Sir, PR interval is around
No, rhythm.
120 to 140 milliseconds. Rhythm, sir, is sinus rhythm, sir. As P wave is present and heart rate, you said 78 milliseconds, 78
Okay.
beats per minute. Yes, sir.
All right. So you remember that we discussed there is P wave before Qrs complex. That means the atrium is the driver.
Yes, sir.
Look at the P wave in lead 2, 3 AVF. How do they look?
Sir, it is inverted.
So where is it coming from? Upper part of the atrium or the lower part?
Sir, I think it is from the lower part.
Exactly. So it's not
Actually, sir, I
sinus, right?
don't- Yes. Yes, sir. Yes, sir.
So this is where it becomes important, the P wave morphology. So if it were sinus, it will be positive in 2, 3 AVF. It is not positive. It is negative in 2, 3 AVF. That means it is coming from bottom part of the atrium. So what is the rhythm then?
Yes, sir.
What will you call this rhythm?
Sir, sir, supraventricular rhythm, sir.
No, that's the general term. This is an ectopic atrial rhythm.
Yes, sir.
Atrial rhythm. Good. So now we have ectopic atrial rhythm, normal PR. Qrs duration?
Qrs duration is, sir, around 0.6 to 0.8 millisecond.
2 boxes.
Yes, sir. 0.8
So 80 milliseconds.
0.08 millisecond, sir.
Okay. And then Qrs, what do you think of the Qrs axis? Normal or abnormal?
Normal, sir. Positive.
What? Yeah, because lead 1 is positive, AVF is positive. Okay. And then QT interval. I'll give you the QT interval. It's about 360 milliseconds. Forget. And then
Yes,
ST
sir.
segment.
Normal, sir.
Yes. ST segment.
ST segment. That is normal, sir. No, I think no, there is no ST depression. A mild ST depression, sir, but it is, I think, not significant to term it as abnormal or significant.
Sure. I think you are right. It looks kind of depressed, but I think it's on the isolate line. How about the T wave?
Sir, T wave in. Sir, I think T wave is normal, sir, except, sir, in.
Look at lead 2.
Okay,
sir,
sorry, sir. I think it's, sir.
You are right. So this is what's happening. If you look at lead 2, positive, negative, positive, 3 same, AVF
Yes,
same, V5,
yes,
V6. So this is a biphasic T wave.
Biphasic T wave, yes, sir.
What is ectopic atrial rhythm?
Yes, sir.
With inferolateral T wave change.
Yes, sir.
This is not compatible with any electrolyte. So the whole point is you have to think simple unless something is looking at you. So this is nothing more than that. And this T wave change, can it be due to ischemia? It's a possibility. And if you want to make a comment that considers ischemia, I'm fine with that. So, but remember the P wave morphology. That was the purpose for me to give this ECG.
Yes, sir.
This one I'm going to skip. I think we should go later on. I want.
Sir, আমার একটা কোশ্চেন, স্যার আমার একটা পার্সোনাল কোয়েরি স্যার। স্যার আরেকবার যদি বাইফেজিক টি ওয়েভটা স্যার একটু আমাকে বলতেন স্যার, মানে বাইফেজিক টি ওয়েভ আমরা কখন বলবো স্যার, জাস্ট একটু স্যার।
So I'm going to go back ECG. If you look at this ECG, it's upright or negative. In lead V1 is negative, V2 is upright. But if you look at this one, this T wave, I'm just pointing towards V5, if you can see, this part is negative and this part is positive. So that's why I'm calling biphasic. And most of the time you see the other way around. You will see a little bit of positive and then followed by a negative T wave. So that's why we're calling it biphasic T wave. And I'm going to bring more ECGs later on. You'll be able to see that. So if it is not positive or negative, it's just two morphology in the same T wave. That's why it's biphasic. Is that okay?
So it is diagnosis is sir ectopic atrial rhythm with sir biphasic T wave.
Yes.
With sir. Yes,
Yes.
sir. Thank you, sir.
Absolutely right.
Thank you, sir.
I need one more volunteer. This rate, I'm going to give you the rate. Rate is 90 beats per minute. Any volunteers?
জুম ইউজার নামে যিনি হ্যান্ড রেজ করে আছেন, প্লিজ আপনার পরিচয় দিয়ে কোশ্চেন করবেন। ওকে, হানিফ তৌহিদ প্লিজ।
Assalamu alaikum, sir.
Dr. Hanif Tawhid from Sylhet. Walaikum assalam.
Sir,
Dr. Hanif Tawhid.
it shows there is no P wave here. The rhythm is irregular. There is no P wave here, sir.
Okay.
Sir, the Qrs complex.
No, let's stop. So rate is 90, and there is no P wave. And you said, is it irregularly irregular?
Yes, sir. It's irregular.
So what is the rhythm then?
It may be, sir, atrial fibrillation.
Absolutely right. So rate was 90, rhythm extremely irregular, and then there is no P wave, and you can see this fine wave in lead V1 or V2.
Waves.
It's fibrillatory wave. Now, if you look in lead V2, it may look like a P wave, but if we come back a little bit no, there is no P wave. So it's atrial fibrillation. So there is no point of measuring P and Qrs duration.
So Qrs durations are 80 milliseconds.
80 milliseconds. QT interval, I'm going to tell you because it's very difficult to measure here, but over here it's about, in lead 1, I can see QT interval is about 360 milliseconds. What else can you tell me about this ECG?
Sir, there is, sir, T wave. It is, sir, ST. There is no ST segment change, and there is a T wave. Is sir flat in lead 3 and ABF.
Yes, the T wave is flat. Is there anything else you can tell me from this ECG?
Sir, may I tell?
Yes.
Sir, there is poor RV progression, I think, sir.
Absolutely right. So that what it means that if you look at my earlier ECG, I'm going to go back. That, like, look, this ECG V1, V2 by V3, the R wave is dominant. Over here, V1, very small R wave, V2 still, V3 is small R wave, V4 is small, and it is at V5, V6 where it became dominantly positive. So it's poor R wave progression. And there are many reasons for it. One, maybe somebody did not put the lead right. Heart can be rotated. Sometimes you can see this in patients with COPD, or you can see in myocardial infarction. So when we see poor RA progression, we just report it and we say consider this. And it is up to the clinician to decide. So what is your final conclusion?
Sir, my final conclusion is, sir, atrial fibrillation with poor RA progression. There is clockwise rotation maybe.
Perfect. That's it. Nothing more than that. I think the important part, I think, if I look at a primary care setup practice, that if I can tell this is atrial fibrillation, that's good enough. And there is no other gross change. That's what we need to know.
Sir, thank you, sir.
Okay. I'm going to go into the rhythm again. This rate is 115 beats per minute. Anybody?
Dr. Maisum Sobahan, please.
जी सर, अस्सलाम वालेकुम सर।
Namaste.
जी सर, The rhythm is the sinus rhythm, as there is sinus tachycardia, sir. Heart rate is around greater than 100 beats per minute.
Yeah, and I told you
More than-
115 beats per minute. 115
sir.
beats per minute.
Yes, sir.
And is it regular or irregular?
Sir, is regular.
Okay. And why did you say sinus?
Sir, there is a P wave.
Which lead can you see the P wave?
Sir, in lead lead P1 there is P wave, and sir in
Good.
lead
Yes.
P5.
Okay. Okay. You
Yes,
can
sir.
see, yes. So you can see a P wave in lead V5. You can see a P wave immediately. But don't you think it's a little too close, the Qrs
Yes, sir.
complex?
Yes, sir, it is very close
Yes.
to Qrs complex.
How about 2,3 AVF?
Sir, in 2,3 AVF there is no P wave. I
Or
think,
if there is a P wave, it's a negative P wave?
no, it's a negative, sir. Ectopic atrial activity, sir.
Okay. So this is a problem for us. So
Yes,
this
sir.
patient now has a heart rate of 115 and this rhythm. So there are few possibilities. One, as you said, sinus tachycardia, but the lead 2,3 AVF, there is negative wave before the P wave. So it is not sinus. Second,
Yes, sir.
is it other than sinus? One of the things that I look at is if this patient has this ECG and 2 hours later, heart rate is still 115, it cannot be sinus tachycardia. Please remember, sinus tachycardia never stays in one place. It will move. It will be 115, 113, 118. If we look at lead V1 carefully, can you see my pointer?
Yes, sir. Yes, sir.
Yeah, there is a P wave. Look at,
Yes, sir.
maybe there is a P wave here.
Yes,
So,
sir.
there are 2 P waves and 1 Qrs complex. And in lead 2 or 3, if you ignore the Qrs complex, it looks like a saw.
Yes, sir.
So-
It can be a atrial flutter wave, sir.
2 to 1 conduction. Yes, this is the unusual rate for that. Usually atrial flutter is 150, but this is actually atrial flutter. I'm going to go into this. Look at this. When the rate slows down, you can see it better, the flutter wave. It's a different patient, but
Yes, sir.
so this is actually atrial flutter with 2 to 1 conduction. And then
Yes, sir.
rest of it, how about the Qrs complex? Qrs complex duration, it looks good. Any ST segment change?
ST, sir, ST depression in V4 to V6 and
Yes.
V5. Yes, sir. Yes, sir.
Please be careful. Once you make a diagnosis of flutter, that flutter wave can distort the ST segment. And what we will do, I'll say atrial flutter with 2 to 1 conduction appears to have ST segment change, which may be due to the flutter wave. Thank you.
Yes, sir. Yes, sir.
That's
Thank
good.
you, sir.
Okay.
Thank you, sir.
Sir,
Now,
one question, sir.
Yeah, yes, go ahead.
Sir, in this regard of this ECG, and would you please kindly explain explain the QRS morphology on V1, V2, V3, and it's look like the M pattern in
Yes.
overall. But
Yes.
yeah,
So there
would you
is
please
one.
explain the 2P wave in those leads?
Okay. So the 2P
Thank you.
wave,
Sorry.
if you look at lead V1, there is a P wave here. You can see my arrow, right? And then
Exactly.
there is another P wave here.
Uh,
And there is another P wave. The Qrs complex is actually RSR pattern. So this patient has incomplete right bundle branch block. It didn't fulfill 120 milliseconds. So there is incomplete right bundle branch block and there's a 2P wave. The bottom line is that if you see a tachycardia, which cannot be explained by, if this was sinus tachycardia, either the patient should be running or the patient should be very sick, some fever or something. If this patient has neither of those, patient is not hypotensive, why will that patient have sinus tachycardia? So those clinical scenarios are important. So again, this ECG again shows another patient with atrial flutter. You can see the flutter way better here now.
So one question from my side.
Yeah. Yes.
Sir, previous ECG, sir, what about the ST segment in lead 2, 3 ABF? I think
Yes. That's what I mentioned, that because of the sawtooth appearance of the flutter, that ST segment depression is due to the flutter wave superimposed on the ST segment. So you can describe it as ST segment change, but it is nothing to do with the Qrs complex. Once it is actual flutter, describing the ST segment becomes kind of irrelevant or clinically not, it doesn't correlate. It has nothing to do with ischemia. It's just because of the flutter wave.
So we can't tell it is ST depression.
No, you cannot. I normally do not. When I describe it, I normally do not. Or you can say,
though it seems to be apparently here.
Exactly. What you can say appears to ST segmented, but I believe this is due to the flutter wave.
Okay.
That will be my comment on this.
Okay.
So this is, I'm going to move forward because I think we're getting a little late. Here, if you look at this, heart rate is 72, and there is P wave before each Qrs complex. So there is a P wave is upright in 2-3 AVF, and biphasic in V1, so it's sinus rhythm. And the PR interval is about 130 milliseconds, but the Qrs duration is wide. It's about 120 milliseconds. It's different. And this Qrs is monophasic R wave in lead 1, small r deep S in lead V1, and wide R wave in lead V6. That's consistent with left bundle branch block. What happens that the septal activation initially causes the small R wave in V1, and the terminal force was a wide R wave. And this is typical of left bundle branch block. And this, that when we, in the previous, we were discussing that this is again sinus rhythm. And if you look at lead V1, it is an M pattern. M, the initial R is small, second R is bigger. And then in V6, there is narrow R wave and then followed by deep S wave. This is very typical. Basically, this is right bundle branch block, and the other one is left bundle branch block. And please remember these two patterns. This is sinus rhythm with right bundle branch block. The other one was sinus rhythm with left bundle branch block.
So one question.
Yeah. Go ahead. I couldn't hear you.
Just previous ECG,
yes.
Which we mentioned, the left right bundle branch block. This
yes.
is also the left axis deviation, and we could see the bifascicular block.
Yes, but yes, you're absolutely right, because there is left anterofascicular block, right bundle with left anterofascicular. Fantastic. That's great.
Another question of previous ECG, please, sir. Previous ECG, we mentioned the previous ECG. This, yes, sir. Yeah. In this ECG, it is clear that the wide Qrs complex in the all lead, and I see the V3 in the fragmented Qrs. Is it fragmented Qrs in V3?
Yes. Yes.
Oh,
yes. You know, this, I know there has been a lot of discussion about this fragmentation. Sometimes you can see if there is scar tissue, but you know, for clinical purpose, I don't think we can really spend too much time on this. In the ECG, I'm not going to report it. It probably represents a scar somewhere in the conduction, and you can see the fragmentation. Yeah.
Thank you, sir. Thank you.
Is there anybody who can do this ECG?
Dr. Anwar Said.
Assalamu sir.
Assalamu.
So ECG is sir this one, sir?
Yes.
Sir, ECG seems to be like in there is P wave is present.
Yes.
It is in sinus rhythm. P wave is upright in 2-3 AVF, and the peer interval is 1-4. Peer interval is 120 millisecond.
Okay.
Roughly.
The rate is about 98.
Rate is about 98.
Yes.
Yes, sir.
rhythm, is it regular or irregular?
Rhythm is not regular, sir.
Okay. Why is that?
Sir, there is P wave followed by Qrs, and then another P wave followed by Qrs, but there is a sinus pause.
Okay.
And there is also some it's a Qrs complex is 80 millisecond.
Yes.
And there is some ectopics are noted in the long lead of V1. There is a ectopic.
This one?
Which is G, sir. Yes, sir.
Okay.
It should be ventricular in origin should be.
Okay.
And
so what's the final diagnosis?
Sir, my final diagnosis is ventricular ectopic with sinus rhythm and with few sinus arrest.
Okay, sure.
Sinus
right.
pause.
So good. So let me look at this. So I'm pointing in V1. You can see one beat.
Yes, sir.
And then there is a P wave here, followed by Qrs. And there is a pause, but it's not a long pause. Not long enough to define sinus arrest.
Okay, sir.
And then there's a P wave, Qrs, P wave, Qrs, P wave, Qrs. So it is more compatible with sinus rhythm with the atrial premature beat. Sinus rhythm with the atrial. So atrial premature beat in a pattern of bigeminy. And then
yes,
if you continue looking at it, it's a bigeminy pattern. And then here, again, there is a P wave here, followed by the Qrs. And this Qrs is wide, but it is a right bundle type, because if you look at lead V1, it looks like a right bundle. It's
Sir, one question here in V1, you are showing now a P wave, sir,
yes.
By the pointer. So
yes.
Where is the T wave here? Is there
it's fused. This is V1. Okay, look at this one.
Fused with P. Or
okay, look at this. This T wave, this is the T wave, negative. Here, it has distorted. That distortion is because of the P wave.
Yeah, I think P is fused here with P.
Exactly.
So looks biphasic, negative and positive.
Looks biphasic. So that's why you
this
have to
negative
compare.
Pass is for due to T and positive for P, I think, for positive
exactly.
reflection.
Positive is the P. The negative part is the T wave. So the only way to know it is if there is a previous one without similar complex. If I did not have this one, I could not have said anything. But also that distortion is present here, a little bit distortion. So there is a P wave, and I think this P wave conducted with aberrant. So this final diagnosis is sinus rhythm with frequent supraventricular premature beat in a pattern of bigeminy with one aberrant conduction. This is not ventricular premature beat. This is just an aberrant conduction.
So as it is not present in all the leads, so this is not premature ventricular contraction. As there is P wave is there.
Yeah, exactly.
Yes,
exactly.
Sir.
P wave. There are
Thank
few
you,
things that support aberrant conduction. Aberrant conduction is mostly right bundle type, and this is right bundle type. You can also see left bundle pattern, but there is definitely a P wave and right bundle pattern. Both of these supports an aberrant conduction. Is it possible that it's a coincidence? Yes, but very unlikely coincidence. So this is another one with, if you look at, it's a little different, sinus bradycardia, PQRS, and then there is a premature beat. And then PQRS. So this is, again, sinus bradycardia with supraventricular premature beat in a pattern of trigeminy. So 2 normal beat followed by 1 premature beat. And there is a way to, we will go into this discussion how to differentiate between PVC and in a later date. I'm just going to look at few more.
Sir, maybe it's APC, atrial premature contraction.
Yes. Exactly, atrial premature beat.
In the previous ECG, sir, in the previous ECG.
This one?
Previous ECG.
This one or that one after
this
that?
one, lead 2.
Yes.
The lead 2 is there is second beat is APC maybe, sir.
Yes. You have to look at the rhythm strip in V1. First beat is the sinus, second is the premature beat.
Premature, yes, sir.
Yes. So that's the pattern of by Gemini.
Thank you,
And
sir.
over here, if you look at lead 2, first beat sinus, second beat sinus, the third beat is the premature beat.
Premature, sir.
Sinus, sinus, premature beat.
Premature, sir.
Sinus, yes, exactly.
Right.
So I think it has been an hour. I think we should stop here and I'll take questions and then we'll finish the session. Dr. Yasin, is that okay with you?
Yes, sir.
And do you like this interactive format?
Yes, sir. Sir, question এর মাঝে আমি স্যার একটা কোশ্চেন একটা আছে স্যার, what is the mechanism of ROF progression?
Oh, for ROF progression. Okay.
Mechanism of ROF progression, sir.
Okay, I'll show it to you. I'm going to go back. Here is our wave. See, this is not rightly done. V1 should be here. So it depends where is the ventricle. Because the right ventricle and the left ventricle. So if the heart is rotated this way, it will develop poor ROF progression. That's one. And it can happen just people will have, some people have rotated heart, or it can happen with COPD. The other thing is that it can happen in left ventricular hypertrophy. There is some rotation. And myocardial infarction is one of the causes that has been explained as the poor ROF progression. Any other question?
Next question. Yes, sir. Next question from Mahmudul Hassan. How there is 12 leads we use but get, how there is 10 leads we use but get 12 leads ECG?
Oh, okay. I actually took away stuff I wanted to show that we have, Mahmoud pointed out that the question is there are 6 leads here and then 4 10. So what we do augmented lead. So right arm, left arm gives lead 1, left arm, left leg gives lead 2, then right leg, left arm is AVF. And then we can augment them with AVR, AVL, and AVF. These are augmented lead. What happens, they are disconnected and connected to a single, it's not a bipolar lead. And so we have these 3 leads that are coming as an augmented. And then we have 3 limb leads, 1, 2, and 3. So that's 6, and the chest lead 6. That gives us 12 leads.
Sir, Dr. Shafiqul Islam এর একটা কোশ্চেন আছে স্যার। স্যার, ইসিজি লিডে শুধু টি ওয়েভ ইনভার্সন থাকলে কখন ইসকেমিয়া কমেন্ট করব?
Which lead?
স্যার, কোন লিডে যদি স্যার মানে কোন লিডে টি ওয়েভ ইনভার্সন থাকে, আপনি স্যার যে কোনো লিডেই কখন ইসকেমিয়া বলবো স্যার?
So if I look at this my ECG, can you see it? Like lead V1, T is inverted, but the QRS is also negative. So that's the normal pattern most likely. If we look at lead V6, QRS is positive, T is positive. If this T wave becomes negative, then I'll call it abnormal. And there are different types of T wave change. Some of them symmetrical change, asymmetrical change. Based on that, we make comments. Consider ischemia. Some of them are related to left ventricular hypertrophy. But the bottom line is that look at the QRS. If it is moving away from it, then it's abnormal.
So next question from Shubhagata Shaha. Sir, how do we differentiate wrong lead placement from dextrocardia?
Oh, okay. The question is wrong lead placement versus dextrocardia. If you give an ECG and I don't have the patient, I will you will have to look at the dextrocardia will mainly happen in chest leads, and it will look exactly reverse of what it. That's one. Second, the P wave will be upright in 2-3 area because it's dextrocardia. The P wave didn't change. It's the Qrs complex in the limb lead and the chest lead. And I'll find an ECG in the next session. We're going to bring it up. But please remember that if I put the electrodes wrong, I can make an ECG which will look like dextrocardia, which is not really dextrocardia.
স্যার এত কোশ্চেন আসছে স্যার, আমরা সারা দিনে শেষ করতে পারবো না। আমি স্যার 2-3টা কোশ্চেন নিয়ে স্যার সেশন শেষ করবো স্যার, কারণ আপনি আমাকে টাইম ফ্রেম বেঁধে দিয়েছিলেন স্যার। স্যার একদম একটা বেসিক কোশ্চেন স্যার, এটা অনেকের মাঝে আছে স্যার। স্যার ইসিজি লিডে এসটি ডিপ্রেশন থাকলে কখন ইসকেমিয়া বলবো? একদম ডাক্তার মাইসুম সুবহান ফ্রম ঠাকুরগাঁও।
Yes. Okay. So one of the ECGs that we did, we'll do something like this ECG. Had sinus tachycardia, there is down-sloping ST depression lead 1 AVL, V4, V5, V6. Use horizontal or down-sloping suggest ischemia. If it is up-sloping ST depression, we do not call that ischemia. But please remember one thing, that ischemic ECG must be dynamic. That means you do an ECG now, it is 1 or a little bit later, it is worse. And of course, the other question is the patient's symptom. If the patient has absolutely no symptom and you see a fixed ST segment change, that's probably not ischemia. But we will call it considered ischemia. But to answer your question, if it is down-sloping or horizontal, that is suggestive of ischemia rather than up-sloping ST depression.
স্যার আমি আরো 2টা কোশ্চেন একসাথে করি স্যার, ডক্টর রেজাউল করিম এবং ডক্টর নাজিমের। ডক্টর রেজাউল করিমের কোশ্চেনটা একটু ডিফারেন্ট টাইপ কোশ্চেন। আসসালামু আলাইকুম স্যার, if ECG not available, how do we approach to a patient with palpitations?
Okay. So the question is, if somebody has palpitation and there is no ECG, unfortunately you can't, because how you have to record ECGs, some modality of ECG. I mean, Bangladesh now, when I was a medical student or even a registrar, there are only 2 ECG machines in North Bengal. In Bangladesh now, there is ECG everywhere. So that is an immaterial question at this point, I think.
Sir, next question. Sir, what is the importance of biphasic P wave?
The biphasic P wave depend on where the location is. If you look at lead V1, initial part is positive, terminal part is negative in this ECG. What happens? V1 is situated in the center, almost at the center of the heart. So the electrical signal will first go from the sinus node, it will first go towards V1, so it will become positive. That's the right atrial activation. And then it will move to the left atrium, which is moving away from V1. And that's why the terminal part is negative. So that's the way we get biphasic P wave in lead V1. In other leads, you will not see biphasic. In other leads, you will either see positive or negative. It is only in V1 that you will see biphasic P wave.
Sir, last 2টা কোশ্চেন নিয়ে স্যার আমরা সেশন শেষ করছি স্যার। ডক্টর সাইফুর রহমানের কোশ্চেন, স্যার হোয়াট ইজ দ্য পারপাস অফ লিড এভিআর? প্লিজ এক্সপ্লেইন। ফার্স্ট কোশ্চেন। সেকেন্ড কোশ্চেন স্যার, এটা হচ্ছে ডক্টর মাহমুদুল হাসান। স্যার, হাউ উইল উই পিপল লিভস ইন amputate limb or
useless lead that is there? Lead AVR actually tell us P wave morphology, because lead AVR looks into the cavity of the ventricle. In one situation that is important is if somebody has left main involvement with acute MI, you can see ST elevation lead AVR. That is one significant finding. Other than that, it is of limited value. And Mahmoud sir's question is, if somebody doesn't have limb, what we do is that we actually can put the electrode in the torso. So if we put on the right and lower part of the trunk, and if we put in the right upper chest and left upper chest, that will be almost as good as a limb leads. As a matter of fact, nowadays, most of the ECGs that are done in our office, they put it not in the legs or the arm, they put it in the main trunk because the adhesion is better.
Thank you, sir. Actually, sir, question করেছে স্যার ডাক্তার মাহমুদুল হাসান. He passed MBBS from Rajshahi Medical College. আপনাদের দুজনের এই বিশাল ফ্যান, and now he is posted in ব্রাহ্মণবাড়িয়া. স্যার আমরা স্যার একদম মানে যেহেতু স্যার আপনি 1 ঘন্টার কথা বলেছেন, অলমোস্ট 1.5 ঘন্টা, আমরা স্যার নেক্সট ডেট স্যার আশা করি স্যার কি নেক্সট ফ্রাইডে কি পসিবল?
Next Friday, yeah, possible, sure.
তাহলে স্যার নেক্সট ফ্রাইডে স্যার সেম টাইম সেম এ থাকবে স্যার আমাদের.
What topic do you want? I mean,
না স্যার আপনি স্যার যেহেতু 4টা সেশন নেবেন, আপনি স্যার ঠিক করে দিবেন স্যার.
ঠিক আছে, I'll do.
আপনি স্যার আমাকে জানিয়ে দিলে হবে স্যার.
Okay,
এখন
sure.
বলতে পারেন স্যার.
I'll let you know. I'll let you know that.
Sure, thank you sir. স্যার আমরা একদম কনক্লুশনে স্যার, it was an extraordinary presentation. এটা অনেকের জন্য লাইফ টাইম অ্যাচিভমেন্ট টু অ্যাটেন্ড ইওর ক্লাস, এবং অনেকের জন্য এটা জীবনে একটা অভিজ্ঞতা যে ওয়ার্ল্ডের ওয়ান অফ দ্য বেস্ট ফিজিশিয়ানের কাছ থেকে ইসিজির হাতে খড়ি হলো. থ্যাংক ইউ ভেরি মাচ অন বিহাফ অফ বিডি ফিজিশিয়ান, এবং আজকের স্পন্সর কোম্পানি ছিল হেলথ কেয়ার ফার্মাসিউটিক্যালস লিমিটেড. স্যার আমরা চেয়ারপারসন কনক্লুশন রিমার্কস দেওয়ার আগে স্যার আপনি যদি কিছু বলেন.
No, thank you. I mean, please, as I told you that there is no right or wrong answer. Please make sure that you read ECG systematically. Don't be afraid to make mistakes. Everybody can give correct answer, but it's always difficult to give wrong answer. So don't be afraid to make mistakes. And by mistake, we learn new things. If I don't make mistake, I will never learn it. If you are afraid to make mistake, you will never learn. So the learning process will be to take the challenge that yes, I can make a mistake, and let's see if somebody else can fix it. Thank you. Thank you.
আজকের অনুষ্ঠান কনক্লুড করার জন্য আমাদের আজকে চেয়ারপারসন প্রফেসর মাহমুদ হাসান স্যারকে আহ্বান জানাচ্ছি.
জি,
প্রফেসর মাহমুদ হাসান স্যার, কারণ স্যারের আসলে সকাল থেকে স্যার নেট খুবই ডিস্টার্ব করছে, পারমিশন নিয়ে স্যার আমরা কি আমাদের সেশন আজকে মতো এখানে সমাপ্ত ঘোষণা করছি স্যার.
থ্যাংক ইউ. ওকে, দেখা হবে আবার নেক্সট
স্যার নেক্সট ফ্রাইডে স্যার. থ্যাংক ইউ ভেরি মাচ স্যার.
ওয়েলকাম.
অনেক লাইভ ক্লোজ করে দেবো.